5 o'clock.
What are your
We are live.
We are live, so we can go ahead.
Yes. Welcome everyone for today's webinar on failed ACLs and revisions. Happy Friendship Day to all the viewers on this occasion. Friends, we have the master arthroscopy surgeon who popularized arthroscopy, probably the first arthroscopy specialist from India, Dr. Anant Joshi from Mumbai. He will be sharing his vast experience on this very relevant topic, that is failed ACLs and revisions today. On the panel, we have Dr. Sachin Tapasvi, Dr. Nagaraj Shetty, Dr. Rajiv Raman, and Dr. Asit Chidgupkar as panelists to take the discussion in the right direction. We also have the Artho TV team led by Dr. Ashok Sham, Neeraj Bijlani, and Dheeraj Attarde to coordinate today's technical aspect of our transmission. Friends, Anant Joshi did his graduation and post-graduation from Mumbai. Then he trained himself as an arthroscopy surgeon, and he was the first to restrict his practice purely to arthroscopy. And he has made name, fame, everything with this arthroscope, and he has popularized this technique by conducting live workshops across India and nearby countries, and he is a well-known faculty in the international platform regarding arthroscopy. He heads the SportsMed in Mumbai, which is a combination of all the joints, like they have people having shoulder, elbow, ankle, hip, and knee arthroscopy and related diseases. They have physiotherapy, osteopathy, sports medicine, yoga, everything under one roof. He is running that. His association with Solapur, I will tell that the first live workshop on an arthroscope was conducted by him in Solapur when I was a resident in medical college. I saw that for the first time. That was a diagnostic arthroscope workshop he had conducted. Then he came again to demonstrate the bone tendon, patellar bone tendon bone ACL reconstruction sometime in 92-93. Then third time he came to demonstrate the hamstring ACL reconstruction sometime around 95, because he was not doing initially the hamstring reconstruction. I know the incidents because Juhi Chawla had ACL rupture when she was in Switzerland during a film shooting, and she was treated with a hamstring ACL reconstruction. And when Anant Joshi saw her, then he was, after seeing the scar, he said that this is what we should also start doing. So he left BTB and immediately he packed and went to Switzerland, learned the technique and came back. And as soon as he came back to India, he came to Solapur also to demonstrate the technique. Again, he was the one who brought Sanjay Desai to Solapur for shoulder arthroscopy workshop along with him. And he again came once to Solapur IMA to give Mule oration. So that time he drove almost 500 to 600 kilometers, because I know he didn't take the national highway to Solapur, but he took the road via Paltan and Aklus. I know that because even after having driven 600 kilometers, he was so active and he was involved in giving that oration on that day. I keep meeting him regularly on so many platforms across India during various conferences. This is recently just before the lockdown on 1st of March at Nashik during the Nashik Con. We chaired the dais for the one of the discussion, and also Dr. Anant Joshi is a fitness freak. I know he came to Nashik on his cycle, because when I saw him first time in the lift, he was carrying the cycle, because his cycle is also very, very precious. It costs almost a bomb for him. So he was carrying. Once we met in South Goa, we traveled together from Bombay to Goa in a flight, and we reached sometime around 11 o'clock to Goa. And I went in the bus with the sponsors are organized, but Anand Joshi had brought his cycle. So from Dabolim Airport to Kanapona, that Hotel Lalit, it's about 70 to 75 kilometer and Ghat section. Even before the bus could reach, so he had reached on his cycle. So that's the fitness he has, and I've seen him coming to Nashik many times whenever I have gone there on his cycle coming from there. Our next panelist is Dr. Sachin Tapasvi. He will be joining little late because he's held up with a surgery. He has completed his MBBS and MS from BJ Medical College, Pune, and he was the topper in the university with gold medals in both the occasion. He was the Asia Pacific Fellow at Queen Elizabeth Hospital in Adelaide, Australia, and here he was interested in the adult reconstruction surgery services comprising of arthroscopy and joint replacement. His talent was very well recognized there, and he was lauded with an appointment as a clinical tutor in the University of Adelaide. He could have stayed there and continued to work there, but he thought he should return to India. After returning to India, he began his working as a consultant in arthritis, sports medicine, and arthroscopy and joint replacement with majority of the major hospitals in Pune, like Jahangir Apollo Hospital, Dinath Mangeshkar Hospital, and Oyster and Pearl Hospital in Pune. Recently, in 2016, he was awarded honorary FRCS by Royal College of Physicians and Surgeons from Glasgow for acquiring distinction as a surgeon in the field of joint replacement and arthroscopy. Friends, Dr. Sachin Tapasvi conducts Pune knee course since 2011 every year, and more than 1,000 people attend every time. Probably after TraumaCon, this is the only conference which has got so many people attending, and he trains 4 fellows per year under him. This is again Dr. Sachin Tapasvi next to me recently, just before the lockdown at NashikCon. Then we have Dr. Nagaraj Shetty from Mumbai. He has done fellowship in arthroscopy and sports medicine from South Korea and as well as in Spain. He has done shoulder fellowship surgeries in Italy, advanced training in France, as well as Netherlands and USA he has done. He is working as consultant arthroscopy and knee shoulder surgeon at Leelavati Hospital, Nanavati Hospital, Hinduja Hospital, and he also heads the Municipal General Hospital, BDBA. He is a PG teacher. He has published numerous research articles in all the leading PubMed indexed journals on arthroscopy and shoulder surgeries. He is a reviewer of the Journal of Orthopedics and Applied Sciences. He is the National Faculty for Arthroscopy and Shoulder Surgery meeting since 2013 and International Faculty for various cadaveric and other courses in Asia Pacific region. Welcome, Dr. Nagaraj Shetty. We have another young orthopedic surgeon, a arthroscopy surgeon, Rajiv Raman from Kolkata. He is a consultant orthopedic surgeon. He is ex-editor of Indian Arthroscopy Society, editor general of West Bengal Orthopedic Association, scientific chairman of West Bengal Orthopedic Association, state representative in the IOA representing West Bengal. Then he is the quiz master for IOA PG quiz, which is being conducted every year, and he has conveyed. He is as a convener and member of Sports Medicine Committee of Indian Orthopedic Association. He has worked. Friends, Dr. Rajiv Raman not only operates in Kolkata, but he also regularly visits Bhutan and Bangladesh for doing surgeries. This is Dr. Rajiv Raman and Dr. Taral Dagra with me about 4 or 5 years back when we had gone to Patna. This is Patna Sahib, where we had taken this picture for one of the conference. He's a regular faculty in major conferences in the Northeast region as well as in the Northern region. Welcome, Rajiv. Then we have a young orthopedic surgeon, Dr. Asit Chidugupkar from Sholapur. He's a third generation orthopedic surgeon. His father is also an orthopedic surgeon. His grandfather was also an orthopedic surgeon. He runs a very big hospital, Chidagupkar Hospital, which is very spacious. You can see this is just the entrance. Almost about 50 to 60 cars can uh, park before we can reach the building, which is behind this coconut tree. So on a huge area, just in the heart of the city, they run this hospital. He's also very actively involved in joint replacement as well as arthroscopy, and he is very well trained both in Pune and Mumbai, as well as under Dr. Rajgopalan in Delhi. He has done fellowships in both joint replacement and arthroscopy surgery before coming back to Shulapur and running this hospital. He's a very good trauma surgeon also. Welcome, Asit, for this today's meeting. Friends, let's begin. I'll ask Dr. Anant Joshi to proceed with this talk, failed ACLs and revision surgeries. Welcome, Dr. Anant Joshi.
Thank you, Shiv Shankar, for this kind introduction. And I'm extremely happy to be a part of the IOA teaching program initiative that you have taken. And I must congratulate you, Neeraj, Sham, for doing such excellent work. The new epidemic that we are seeing currently on the scene in arthroscopy is basically failed ACLs. And therefore, when I decided to choose a topic, I felt that this was probably the most apt topic that I could talk on. I also felt that instead of quoting papers and looking at literature, I would rather share our own experience with this new challenge that we are facing, failed ACLs and revision, and share our experience, which we have seen over the past maybe a decade or so since revisions have become fairly common. Now, the role of the anterior cruciate ligament as a crucial stabilizer of the knee has been recognized since long, from the early 1900s. It was also recognized that once the anterior cruciate ligament was torn, the kinematics of the knee was disturbed. There was a disturbance in the rolling and gliding mechanism of the femur on the tibia, resulting in progressive damage, and this disturbed kinematics resulted in secondary damage to the menisci, articular cartilage, and gradual stretching out of the secondary restraints, and eventually, if left unattended, led to early traumatic arthrosis. And this was what stimulated surgeons to look very closely at this ACL deficient knee. In the 60s and 70s, the surgery for ACL was largely experimental, and surgeons were trying to experiment with all kinds of techniques, some of them restricting purely to extra-articular techniques, then to intra-articular techniques like suturing the ACL to the PCL, which was called the Vitex procedure. Later on, they tried out the bone patellar tendon bone, also the hamstrings, trying to have a vascularized graft. Finally, it was in the late 80s. However, you found that in the 60s, 70s, and 80s, early 80s, the reports of ACL reconstruction were largely few and sparse. And this was probably because this was open surgery, and the complications of this surgery were quite high and not acceptable to most patients. So it was only in the later part of the 80s that arthroscopic ACL reconstruction was then established as a standard procedure. And today we know that arthroscopic ACL is the gold standard for managing an ACL deficient knee. Now, during the early days of the introduction of arthroscopic ACL, it was basically felt that the ACL was an injury of athletes, and it was only athletes who needed a stable knee and required surgery. It was only later, when we started opening up our minds to the general population, we realized that the ACL injuries are not only during sports, but also during accidents, during activities of daily living. As you can see, you can slip and fall in the bathroom and rupture your ACL. You could also have trivial accidents like this in a city of Bombay where people are lazy to cross the platforms through an overhead bridge. They might jump across from a platform and land up with a ruptured ACL. We have also seen ACLs tearing during recreational exercise and sports, and the Garbha season is a boon for us because we see a lot of patients coming with a torn ACL after playing Garbha. And of course, in the smaller cities as well as the bigger towns now, the two-wheeler is what contributes to a large percentage of ACL ruptures. The surgical technique of an arthroscopic ACL is fairly straightforward. And what we intend doing in this technique is basically harvest a strong graft. And this graft could be the surgeon's choice. You have various choices today. You can have the bone patellar tendon bone, which was at one time a gold standard. You could have the hamstrings. Today, we are also looking at the quadriceps very closely, the central quadriceps tendon, and also the peroneus longus. But these, besides these, of course, you have allografts which can be used for the ACL reconstruction. The next point, which is very important, is that harvesting the graft needs to be, the harvested graft needs to be precisely positioned at the anatomic footprints of the native ACL. It needs to be securely fixed with minimal violation of biology during the procedure. And this, of course, needs to be followed up with a customized rehab program. Now, despite this procedure being a straightforward procedure, we see a large number of ACL reconstructions that have failed. And this failure can range from a probably acceptable 77% to a dismal or an unacceptable 25%. And this is why we need to pay closer attention to what we call as the failed ACL. Now, what is the definition of the failed ACL? The goals of an ACL reconstruction are mainly to restore stability to the knee, which is unstable, have a pain-free range of motion, which does not have any flexion, deformity, or extension deficits, and return to pre-injury level of function. And for the patient, if any of these goals are not met, then for that patient, it is a failed ACL. There is a wide spectrum of failed ACLs that we commonly see in practice. On one side, you can have a failure where salvage is possible and one can do a revision. But on the other end of the spectrum, you could have complete disasters where the surgeon has failed to recognize infection and the infection has gone on to osteomyelitis. And these are complete disasters where you are not just trying to salvage the knee, but sometimes the limb as well. So the failed ACLs have a wide spectrum of presentation, and one can see on one end of the spectrum a recurrence of laxity, which may be very subtle. That means the patient may have a subtle pivot shift, or there may be gross laxity, and the patient will voluntarily show you anterior posterior translation of the tibia. There may be also presentations with persistent pain after an ACL reconstruction, recurrent effusions, and in a fairly large number of patients, restricted range of motion. And this restricted range of motion again can extend from anywhere from 5% to 24%. So when you have a patient with a failed ACL, one must make sure that the patient does not have any restricted range of motion. Here is a classic case where you can see that the patella on the unaffected side is fully mobile. On the affected side, the patella is adherent and stuck. The patient has an effusion. And if you look at the range of motion, it is restricted significantly to less than almost 90 degrees. So these kind of patients are going to be significantly handicapped because they don't have full extension, they don't have flexion. And very often these patients start thinking, why did I undergo an ACL reconstruction in the first place? I was probably better off without an ACL reconstruction. reconstructions of the ACL may fail early, and these early failures are commonly seen between the first to the sixth month. And these can be when the patient really says that the knee never felt stable after an ACL reconstruction. There is failure to regain range of motion. The patient may have recurrent effusions, or he may have established infection. The other group of failures which commonly are seen probably after a year after an ACL reconstruction are where the patient says that he felt okay for some time, the knee felt stable, or they even went back to their normal activities. And after that, they had gradually recurrence of the laxity where they had, and these can be probably related to attrition rupture, overlooked secondary laxities, or biological failure which is unexplained. And in some cases, the patient may have had a re-injury after an ACL reconstruction. Now, an analysis of the failed ACLs show that almost 74% of these failures are because of inadequate tunneling. There are also other technical errors which can happen. For example, the graft could be so short that there would not be any graft in the tunnels for ligamentization or biological integration of the graft. You may have peripheral lesions which have been overlooked, and of course, infection. In general, in fact, if you want to simplify this, you can say that the surgeon's errors account for almost 80 to 85% of all failed ACLs, and the remaining factors are really not those that really matter during the failed ACL. The causes for failure can be right before even you start the surgery, and this can be pre-operative, intraoperative, and post-operative. During all these three phases, one could land up because of with a failure. Now, let me start off by improper case selection. I think we are so engrossed with this enigma of an ACL that we often overlook other associated injuries. And one needs to be very careful when you diagnose an ACL tear. We have seen currently that often surgeons are so dependent on MRIs and investigations, they hardly listen to the patient's history, and the ACL was never a culprit. We have seen patients who have undergone ACL reconstruction for so-called bruised ACL. The MRI reports a grade 1, grade 2 ACL rupture, which in fact is not relevant at all to the patient's problem. And patients without any history of trauma have undergone an ACL reconstruction just because the surgeon decided that on the MRI, it was a sprained ACL. And this, of course, can result in disasters and failure of the ACL. The other misdiagnosis which we have seen is a posterior cruciate ligament lesion, where actually the surgeon has gone and repaired reconstructed the anterior cruciate reconstruction. And it is not only in India, even Strobel, in a place like Germany, where we expect that surgeons should be familiar with the ACL, he has found that 15% of patients with a PCL deficient knee had undergone an ACL reconstruction. And of course, this is disastrous for the patient because the normal ACL has been removed, the PCL goes unaddressed, and the patient has undergone an ACL reconstruction. Here is one such patient. He had undergone a double bundle ACL reconstruction, and now you had no grafts left on this side. And this is what the patient had. She had a gross PCL PLC, and you had to address this problem. He also had, in addition to the PCL, associated collateral laxities. So I think it is very important that surgeons don't get focused or enamored so much by the ACL deficient knee that they forget the periphery of the knee and the other cruciate and collateral ligaments. The posterolateral corner of the knee and injuries to the posterolateral area are extremely common after an ACL injury. They concomitantly happen during the initial trauma, and almost 14% of failed ACLs have an overlooked posterolateral corner injury. Now, today we have a large number of young surgeons who have access to arthroscopy and arthroscopic equipment. These scalpel wielding surgeons basically are in a hurry to operate on the ACL because they are constantly worried that the patient might go elsewhere and get operated. So surgery is carried out very often in the acutely injured knee. We know that there are a number of collateral injuries that occur with the ACL, especially on the medial side. You can have high-grade medial collateral ligament injuries. You can have significant injuries to the posterolateral corner. And if one operates without healing of these injuries, there is a high possibility of arthrofibrosis. And hence, unless a patient is put through a proper prehabilitation program and the knee inflammation has reduced, the patient has regained full range of motion, one should not carry out an ACL reconstruction. In our setup, we hardly ever do an acute ACL. We wait for almost 6 to 8 weeks after an index injury before we plan an ACL reconstruction. This helps in two ways. One is you find out whether the patient really requires an ACL reconstruction and whether he does not have he has instability and has a symptomatic ACL deficient knee. The second thing is doing ACLs in an arthritic knee. The main reason for doing an ACL reconstruction is to prevent arthrosis from happening. And if the knee is already arthritic, it makes absolutely no sense in doing an ACL reconstruction. And you are going to land up with a patient who is never going to be happy. Like the posterolateral corner, one of the areas which has been overlooked is the posteromedial corner. And a subtle injury to the posteromedial side is the ramp lesion, of course, which we are now looking at more closely. This is to show you that there is an injury to the posteromedial corner. There is a meniscus rise sign which is positive. The meniscus can be lifted off very easily. And this is the ramp lesion, which is present in almost 14 to 23% of all ACLs. And this ramp basically signifies that along with the ACL, there has been an injury to the posteromedial corner. And if you don't address these lesions, then the patient is not going to have an optimal outcome after an ACL reconstruction. So ramp lesions in our setup are routinely identified and treated by repairing these. There are only the stretched out ramps which don't have to be repaired or a healed ramp. But majority of the ramps where there is a clear-cut discrete lesion, I feel that one must repair and address these ramps along with an ACL reconstruction. Lateral sided openings are also frequently observed. These could be seen on the posterolateral or the anterolateral side, and appropriate procedures need to be done to address these lesions. I think the concept which I always like to talk about is that the knee should be considered as an envelope with its contents, and the envelope is the collaterals and the capsule, and the contents are the cruciates. And unfortunately, if you keep on looking at the contents without looking at the capsule or the envelope, you can land up with failures. During the intraoperative phase, we know that the surgical technique is easy, but if you overlook any of the steps, I think you can land up with failures. And these can start right from harvesting the graft. So when you do an ACL reconstruction, you need a strong and a robust graft. You cannot compromise in the quality of the graft, whether you're using a bone patellar tendon bone, the hamstring, or the CQT. If your graft is not adequately long and strong, you may end up with a day one failure of the ACL. So this is extremely important that you don't lacerate and weaken the graft where you're doing a graft harvest. The next thing that we need to focus on is tunneling. And here the commonest mistake that has been found is tunneling on the femoral side, especially too far anterior placement of the femoral tunnel. And this is what needs to be avoided. So you can see that the femoral tunnel in a number of cases that you come across which are failed have ended up with a vertically placed ACL graft, where you can see that the femoral tunnel is almost at the 12 o'clock position if you are believing in the clock position. And this of course leads to significant laxity even after you have done an ACL. Or the surgeon could be erring and going too far posterior. As you can see in this case, there has been a posterior cortical blowout. There is absolutely no fixation of the graft on the femoral side. And this, of course, is a day one failure of an reconstructed ACL. Similarly, you can see that in this case, it is a vertically oriented ACL and the surgeon has missed out on a lateral sided opening, and this has resulted in failure. Now, with our focus so much on the femoral side, we also find that the tibial side tunneling also can be grossly wrong. And here you can see in this video that the tunnel is too far anterior on the tibia. You can see that it has encroached over the intermeniscal ligament. And of course, this is going to lead to impingement in the intercondylar notch. Similarly, you can have a too far posteriorly placed tibial tunnel. Here you can see that the tibial tunnel is so far back posterior that it is almost close to the PCL. And here you have a vertically oriented and the tibial footprint is completely bare, and that is where the tibial footprint should have been. So one can err on both the tibial as well as the femoral sides. The tibial plateau, the tunneling could also be too far medial. As you can see here, the surgeon has encroached completely on the medial tibial plateau. And of course, the patient is not going to be happy after this because he's going to have an impingement. His articular cartilage is grossly damaged, so he's going to have continued pain. And this is another example where you can see that there is encroachment, and in fact a large part of the medial tibial plateau has been damaged because of the tibial reaming. You can also have a completely laterally placed tibial tunnel, as can be seen here. The surgeon has gone too far lateral, and this is what happens. The graft starts impinging, and of course this is not going to function and neither restore normal kinematics of the knee with this kind of placement. An area of concern, of course, before you pass your graft is the notch. And if you feel that the notch is not adequate for your graft, one must do a notch plasty or a roof plasty prior to graft passage. So this is extremely important because you want a non-impinging graft. By a non-impinging graft, we mean that the graft should not impinge either on the roof of the intercondylar notch or on the PCL. So this is a graft which is impinging on the PCL, and you saw that a graft which was impinging on the lateral wall as well. The other problem which one must be careful about is the fixation that you use and the precision during fixation. As you can see on the extreme left, the endo button is in the suprapatellar pouch. This patient had continuous retropatellar pain and clicking. And as you can see, the endo button is sitting in the suprapatellar pouch. There was another endo button which was not against the cortex at all, and it was floating in the suprapatellar pouch. You can see on the tibial side an extremely large screw, which is disproportionate to the size of the tunnel. And sometimes these screws can actually rupture the graft on day one and cause a lead to a day one failure. These are other screws which have not been carefully been placed, and you can see that the screw has already migrated in either the medial gutter or the posteriorly. And it's not just the problems of screws. We have seen migrated endo buttons and endo buttons lying in soft tissues, and these all result in failed ACLs. When preparing the graft, one must make sure that you don't have poor material to fix these grafts. Porcelain tapes which were earlier used before the closed loop systems came into place were not very robust, and these can easily tear, and if your knot tying is not secure, they can lead to day one loosening of the graft. The graft should be tensioned after cyclic loading of the knee after you have fixed the femoral side. And if the cyclic loading is not done, you may not take away the creep from the graft, especially when you are using a hamstring graft, and you may land up with inadequate graft tensioning and again a day one failure. When it comes to rehab, prolonged immobilization, too fast mobilization, too aggressive rehab can lead to graft failures. We have seen patients who have started going into sporting activities within 2 months after an ACL and landing up with an ACL rupture. Forcible manipulation should not be done whenever you are having problems with restricted range of motion. And today you need to be very careful with what the physiotherapists are doing with your patients. We had a patient, an elite athlete, who was doing extremely well. He had almost 90 degrees range of motion by the third week after an ACL, but the physiotherapist wanted to show the new technique that she had learned. So she needled the joint. This poor chap landed up with infection, and it almost took us 6 months to get rid of the infection, which had happened after needling of a joint. So these are the technical reasons where the surgeon is responsible for majority of these. So the pre-op, post-op, and intra-op, and this is just a summary of what I have already spoken. Now, once you have a failed ACL, you need to decide what has the patient come to you for. Has the patient come to you for managing his instability? Has he come to you for a painful knee, or has he come for to you to manage pain as well as instability? And one need, you're treating the patient and not the MRI. So just because the MRI shows that the ACL has ruptured doesn't mean that you should revise every ACL that you see. Now, planning of the failed ACL is extremely important because you don't want to land up with a second failure. And one must be meticulous in examining these patients, starting right from the gait of the patient to see if the patient has any lateral thrust when he is walking. Observe closely for limb malalignment. So if the patient has a varus knee with a thrust, one should make sure that you look at other options when you are treating these patients. Evaluate not just the ACL laxity, but other laxities that may have been missed by the primary surgeon. One must carefully assess for range of motion, because if the patient has fixed flexion deformity or restricted flexion of the knee, and you do an ACL, revision ACL in these situations, the patient may end up again being unhappy with the surgery. Make sure that you have again rehabbed the patient properly and not operated on a limb which has significant muscle wasting or juxta-articular osteopenia because of disuse. So one must be careful and assess the knee very carefully. As can be seen here, this patient has a significant lateral thrust, and if you do an ACL without an HTO, the patient is going to land up with a failed ACL again. So these are the things that you want to find out from the index surgeon. What was the graft which was used? Was the graft adequate size, length as well as diameter? Secondly, was the tunneling proper? And this is what you want to find out during your investigations, your imaging techniques that you use. You want to find out what were the kind of implants were used for fixation. Were they adequate or inadequate? Was the fixation secure? Post-operatively, has there been any tunnel enlargement which is going to hamper your outcomes if you do a revision surgery? Are there any missed lesions because of the which surgery has failed? And is there any low grade sepsis that you are likely to miss? And all these need to be considered before you start with planning your revision surgery. Uh, so once you have done this, you also must look at alignment to make sure that you're not missing out on alignment. Imaging is extensively used before you do your revision. Not just the plain x-rays to find out tunnel positions, implants, tunnel widening, arthrosis, osteopenia, infection. One must also make use, and the 3D CT is something which one must use in every case of a failed ACL to find out the precise location of the tunnel and any tunnel widening. Tunnel widening more than 13 millimeters warrants a two-stage procedure, and one should not hesitate to do two-stage procedure and not try and compromise with a single-stage procedure. Of course, MRIs have their own usefulness in finding out the condition of the articular cartilage and some associated lesions like the menisci, which may have to be addressed during the time of revision. Besides the regular imaging, one must do a full alignment X-ray in every case of revision without fail, the Rosenberg views to find out the condition of articular cartilage. And today, a new thing which has been blamed for failed ACLs is the tibial slope. And for this, one must take a standing lateral view to find out if there is excessive posterior tibial slope, which may account for a failed ACL. So the options when a patient comes to you are varied. One could do a revision ACL. One could just do a revision ACL along with an extra-articular procedure in case there are associated laxities which have been overlooked. In cases where you feel that the patient's intra-articular surgery has been done extremely well, but there is an only extra-articular component that needs to be addressed, one can do only an extra-articular procedure. You can also do an ACL plus an HTO in case of patients who have a graft failure along with a alignment issue. If patients have arthrosis and they have come to you only with pain and not instability, one may consider only a high tibial osteotomy and leave the intra-articular ACL alone, because the patient has come to you for managing pain and not instability. And the last option is, of course, is leaving the patient alone. And this I will briefly talk about in the next a couple of slides. In the revision ACL, one must consider whether you can do a single stage procedure or a stage procedure. A single stage is normally 90% of your failed ACLs can be operated in a single stage because the index surgery has been done very poorly. So you can easily do a single stage procedure. The stage procedure is required in certain situations. Now here is a single stage procedure where the patient had a rupture of the posterolateral bundle of the ACL. This is a failed ACL. The patient came to us with instability. You find that the anteromedial bundle of the ACL was intact. It was only the posterolateral bundle which was torn. And we preserved the anteromedial bundle, and we drilled a tunnel at the PL site. And this is the end result of that revision. You can see that the AM and PL bundles are well preserved. One must make sure that there is no bone debris in front of the ACL and the patient does not land up with any extension deficits post-surgery. So this is one single stage procedure. This is another example where you can see that the femoral tunnel in the previous case was almost way out. And in a single stage procedure, one can reposition this femoral tunnel and do a single stage procedure. Here is another patient where you can see that the ACL was completely vertical. There was what was the empty notch sign, and here we did not touch the previous ACL, and using flexible reamers, we were able to achieve a proper placement of the newly reconstructed ACL. One can also use outside in drilling techniques, and they are quite useful in revision surgery. There are other methods by which you can do single stage surgeries by changing, either increasing or decreasing the angle of your jig to prevent the previous tunnels, especially on the tibial side. You can also do what is known as a tunnel divergence technique, where you can medially or laterally place your tunnel. So other methods are using thicker grafts and larger bone plugs. You can have stacked interference screws if you find that the tunnel has widened and you want to do a single stage procedure. So in this case, you can see that the screw has been stacked. So on the tibial side, you can have two screws to take care of the tunnel widening. Now, stage procedures are preferred when you have joint motion deficits, hardware needs removal, tunnel widening requires bone grafting, and sometimes when you are revising synthetic grafts where you find that the patient has a lot of synovitis. So here is a patient where you can see that there is significant tunnel widening, and here we have planned a two-stage procedure. You can use bone from the banks, and you can use a dowel-shaped graft. This is special both on the tibial or femoral side. You can also use morcellated bone grafts like this. The bone is then used in a syringe which has been cut off, and then you can use these bone plugs on the tibial side as well as on the femoral side. And after you have done this bone grafting, one can do an ACL reconstruction. We prefer to wait for at least 3 months before we do a second stage revision. Now, sometimes patients may come to you with just a pivot shift, which is subtle, where the possibility is that the surgeon has done a good intra-articular ACL reconstruction, but he has missed out on managing or tackling the extra-articular issues. Here you can see that the ACL reconstruction has been done, but the surgeon has overlooked the opening on the lateral side. And here we are doing a Lemaire procedure, which is a lateral extra-articular tenodesis. Here we use a strip of the iliotibial band. We use high tensile suture material to whip stitch the graft. The graft is then passed below the lateral collateral ligament, and it is fixed at a point which is about 5 millimeters proximal and posterior to the lateral epicondyle. And this is the Lemaire procedure, which we commonly do when we have any kind of anterolateral instability, which is associated with an ACL. The other thing which we commonly which we are fond of doing in our practice is combining an ACL with an osteotomy, especially when patients have any kind of malalignment. We feel that malalignment should never be overlooked. The ACL is a soft tissue graft. It cannot control malalignment, and an osteotomy is an excellent procedure which can be combined with an ACL reconstruction whenever, especially in the revision scenario, where you do not want the patients to have any second failures. A thing which has recently been brought into focus is the posterior slope of the tibia, which needs to be addressed when you are doing a revision. And to simplify it, one needs to flatten the slope in case of failed ACL reconstructions. When you are combining a revision ACL along with an HTO, one needs to make sure that the screw number A probably may come in your way when you are passing your ACL graft, and therefore that may have to be removed, and before you drill your tibial tunnel, fix the tibial tunnel and then reposition that screw. So this is what I was talking about, is flattening of the slope. And this may be done in certain situations where you find that the patient has an exaggerated posterior tibial slope that may be responsible for a failed ACL. Finally, do we have answers to all failed ACLs? Definitely not. The pivot shift continues to be an enigma. We had a patient where we had done an ACL, we had repaired his ramp lesion, we had also done a Lemaire, and at the end of it, the patient continued to show or demonstrate a voluntary pivot. When patients have large LFC impacts, on when there are biological failures, we really don't have answers to all these failed ACLs. So revision ACL is not an answer to every patient that comes to you with a failure. You should also consider non-surgical management in less active individuals who have less infrequent instability and who already have significant arthrosis and who are willing for activity modification, rehab, and bracing. So in summary, I think revision ACLs will continue to be a growing problem as the number of ACL surgeries go on increasing. We need to identify the cause of failure to avoid repetition of failure, operate only when indicated. One must not hesitate to combine different procedures so that you have covered all ends of the failure. It needs meticulous preoperative planning, and patients' expectations should be tempered because we all know that outcomes after revision are not as great as after primary ACL reconstructive surgery. Thank you.
Thank you, Dr. Anant Joshi. That was a wonderful exposure to all the revision surgeries, and you have covered all the reasons why it fails and also when to operate and what are the expectations the patient should keep.
So,
Now,
Shivshankar, you are muted, I think.
We can hear.
yeah, others can hear.
I can't hear
Okay.
you.
Okay, now, hello. Asit, can you hear me?
Yes, sir.
Yeah, we can hear.
Yeah, we
Yeah.
can hear you, sir.
We can hear you,
Okay.
sir.
Anand, the problem is from your side. Anant Joshi,
Maybe the speaker
So
is
you have to
muted.
increase volume of your phone
Yeah.
or laptop.
Okay,
Yes.
done.
Okay, fine. Now it's open for discussion. We'll have some questions. Rajiv? Yes.
Excellent lecture, sir, and it was very informative. My first question is, when there is a bone bruise in acute injury, and if there is no bone bruise, so in both the scenario, you plan your ACL reconstruction after 6 weeks, or sometime, suppose patient is coming with a complete rupture of ACL with no bone bruise in the femoral or tibial condyle, you plan it to do it early also.
I think I strongly believe in a compensated and a decompensated ACL. That means even if on day one you see that the ACL is ruptured, very often we have seen that the ACL is edematous or it is detached from the femoral side. Because if you are saying that there is no bone bruise, that means it's a extremely low velocity injury. And in a low velocity injury, you can expect that the ACL is not a mid substance rupture, but probably a detachment from the femoral side. We have seen that these patients very often stabilize, and just as we see that in the case of the posterior cruciate ligament, we have seen the restoration of fibers after a proper rehab program. Similarly, in the ACL, we have seen that there is complete restoration of the edematous ACL, and patients don't have any symptomatic instability at all at the end of 6 to 8 weeks. So I always like to give a trial of conservative therapy before I suggest ACL reconstruction.
This conservative trial, how many months you will give? Because that is a dilemma. When to operate is a question.
If the patient, I always believe that the patient should ask for surgery and the surgeon should not be forcing surgery on the patient.
Okay. Yes, Asit.
Sir, extremely lucid lecture, crisp
Thanks.
and very nice. Thank you, sir. My question to you is, in your huge experience in the last 35 years, you started ACL doing bone tendon bone grafts. At that time, the placement used to be transtibial. So most of the time, the tunnels used to be a little vertical. And then the anatomical positions came in with the semi-T grafts. And now people started doing BTB using an anatomical technique. right? So did you notice any difference at that time when people were doing transtibial that the BTBs were failing, and because of the anatomical positions now that they are not failing anymore?
I think if even when we were doing the transtibial technique, actually what we were doing was a modified transtibial, in the sense that the tibial tunnel was initially drilled with a smaller diameter drill. We then dilated the opening so that we could maneuver the K-wire to get to the appropriate femoral site and then drill the tunnel. And therefore, a lot of my fellows today, even now, when they see my post-op results, they are surprised that we were still in the so-called anatomic location, although we were doing the transtibial technique. Whereas there were surgeons who took their drill and drilled the tibia and the femur in a vertical direction. And I think those definitely led to failed ACLs and a vertical graft with significant restriction of joint motion. So I felt that even with a modified transtibial, one could approach the femoral side if one was careful when selecting the femoral side. There are still some surgeons I have seen, especially in Korea, who continue doing the transtibial way, and they use the modified transtibial, and their femoral tunnel placement is as good as the anatomic placement. So I think the transportal technique definitely is easier, but one needs to modify the tibial position tunnel to place your femoral tunnel at the correct point.
Thank you.
So can I come in?
Yes,
Yes.
Nagaraj.
Yes, Nagraj.
Joshi sir, as usual, absolute excellent lecture. I have quite a few questions, but I'll initially ask based on the pre-operative. So we want to learn from you as to your tips and tricks for the graft selection. Now, let us say you have a young athlete, a young female athlete who's around 17 years of age. We know very well that they are at a high risk of re-rupture. You would obviously be looking at the pivot shift phenomenon. You would be looking at ligament laxity features. So in this case, in this particular patient, would you do something extra always like an LET because of the high risk of re-rupture? Your tips and tricks for this elite athlete who's a young female.
I never go with a predetermined graft choice or a predetermined surgery unless they have an explosive pivot. So if a patient has explosive pivot, I am definitely inclined towards looking at not just the ACL but adding an extra-articular procedure. But if the patient comes to me where I find that the pivot shift is negligible or almost non-existent, then I would not be fixated on doing an extra-articular procedure just because he's an elite athlete. So that is number one. Number two, my graft will determine on the remnant of the ACL. So if the remnant of the ACL allows me to use a slightly undersized graft, for example, if there's a significant ACL remnant and I do get a graft which is probably 7.5, 8, I wouldn't mind using that graft. I wouldn't be fixated again on a size 9 or a size 10 graft. The third thing is I'll make sure that all associated subtle instabilities, for example, like the ramp, and we are very particular about this ramp, which is neglected by a large number of surgeons. We feel that it has to be addressed. If you look at Houston's work on the ACL, you'll realize that he has constantly said that the posteromedial corner of the knee is as important as the posterolateral corner or the anterolateral area. And this area should never be neglected. So in an elite athlete, I think by doing an LET, you may land up with an overkill. And these patients may land up with stiffness. And no patient is happy with a stiff knee. They always want a knee which is pliable, flexible, and a stable knee.
Yes, Asit.
Yes,
So
sir.
the point number two is, if in this elite athlete, I find that there is absolute no remnant of the ACL at all, in the present situation, a 17-year-old elite athlete, we would definitely consider the central quadriceps tendon as an option, as a primary, for using it as a primary graft. Because we feel that the bone in elite athletes as well, and especially in females,
It's 6
the
o'clock.
patellar tendon may not be wide enough for you to sacrifice it, especially if they're in jumping sports. They may land up with significant patellar tendinosis after harvesting the graft, or they may even have a patellar tendon rupture. And the CQT is one which has lesser morbidity, graft site donor morbidity. And therefore, nowadays, we are increasingly using the CQT in these patients where there is no graft remnant.
Yes.
Right.
One question. In my area, we get a lot of Kusti players, the Pahlwans, and I know you are very popular with them. So if there is a Kusti Pahlwan player who comes with ACL and instability, what is your graft choice in these people?
I think the graft choices again, my graft choice depends on the remnant. So if I feel that the remnant is something which is salvageable, and then I get a graft which is 9 or 10, I would still prefer the hamstrings. But if there is absolutely no remnant, it is a neglected ACL with a number of other injuries, then I would still go for the bone patellar tendon bone, the CQT. And very often in these players, again, you need to be very careful in wrestlers. You don't want them to land up with a stiff knee. So you must always compare with the other side, because all of them will have a varus knee. And if you tighten them on their varus on this side by doing an LET procedure, you may find that he is unhappy because he has a painful knee and a stiff knee. So always make sure that in athletes, you compare the normal side before you address the ACL.
Sir, I would like to learn more from you in terms of identifying that patient who is at a high risk of re-rupture. So let us say you have a patient who's got hyperextension, who's got a increased posterior tibial slope. He's got a meniscus tear at the posterior horn. Ominous features combined together in one patient. How would your mind work? Now, other than the biological aspect, there are these mechanical aspects which, you know, when put together, increase the risk of re-rupture. How would you approach such a situation?
So in these situations, again, my diagnostic arthroscopic round before I harvest the graft is extremely important, because I want to identify all lesions besides the examination under anesthesia and the pre-op evaluation. I also want to make sure that I am not missing out on any of the associated lesions. So a root tear of the lateral meniscus, which is commonly associated with a pivot shift in these patients, I would definitely address that. If they have any kind of meniscal tear which is repairable, I would repair that, because we know that the meniscus contributes significantly to stability of the knee. I really don't look so much as laxity, because the patient already has generalized laxity. And again, you have to be careful. If a patient has a recurvatum on one side, the normal side, and if you cannot get the same recurvatum on the operated side, the patient is going to be unhappy. So I still prefer to go with my same philosophy, that I would depend on the remnant of the ACL, address all issues, but not go for an overkill just because I feel that the patient may land up with a failure later on.
So for you, what is the ideal femoral tunnel? Because we have been roaming around the femoral condyle more than on the tibial side.
Yes. So I think basically my philosophy is recreating the footprint, both on the tibial side as well as the femoral side. So we use soft tissue landmarks. I don't like to burn the femoral footprint just to find out where I want the footprint. This may be required only when you have a long-standing chronic ACL where there are osteophytes in the notch, where there are no soft tissue landmarks that you can use. But in majority of the patients, nowadays patients come to us quite early. I think the femoral footprint can be easily identified. It is way posterior in the intercondylar notch, and I use the posterior horn of the lateral meniscus and a soft tissue arch, which is usually present in majority of these cases as a soft tissue landmark for creating my femoral tunnel. So soft tissue landmarks is something that I stress on when I select my femoral tunnel drilling site.
Sir, I have a question with regards. Now you have a patient who had a failed ACL now. It's a revision scenario. And you have identified that the posterior tibial slope is on the higher side. Let's say it's around 12 degrees.
Yes.
It's his first revision. Typically, we know that the slope correction osteotomies, which are quite morbid procedures, this is not coronal malalignment, this is only sagittal slope issue. We know that they typically come in the second revision and the third revision. You know, we see these case scenarios. So I'm giving you a situation where you have identified in the very first revision. What's your threshold of advising a sagittal plane slope correction osteotomy, and what is your cutoff in terms of the angle?
No, the first thing I want to do in this scenario is, before being carried away by this tibial slope, is to make sure that the other side, the patient does not have a similar slope. Because if the patient has a similar slope on the other side, then it is useless for me to even think about correcting the slope, because that is how the patient's tibia is or the knee is. It is only when there is a pathological increase in the slope. And like I said, I had a talk with Feng Hua when I was in Beijing, and he felt that more than 15-degree posterior tibial slope is something that he would look at and correct. But again, in an elite athlete, if you, especially for elite athletes, if you do any kind of these bony procedures, the chance of return to sports is very unlikely. And therefore, I would take my chance, and I would still go ahead and do a soft tissue reconstruction along with addressing the other issues before I jump on and to this slope correction osteotomy. I'm more worried about the coronal plane rather than a sagittal plane when doing an osteotomy.
Okay, thank you.
Yes,
So
Rajiv.
for tunnel, sir, suppose in CT scan you see that the tunnel is widely dilated and you are planning for graft. So how long after putting the graft you plan for your revision surgery?
Almost 3 months down the line. 3 months. So allow the graft to completely incorporate, so it's like a fresh knee that you're going in. But like I said, Rajiv, in our practice, most of the revision ACLs are almost like a primary ACL, because the surgeon has done such a blunder on the primary thing that you don't even have to worry about, except for the graft choice that you are, sometimes you have to go to the contralateral side, because this surgeon has used both the hamstring, gracilis and semi-T, and you're not left with much. So you may have to go for the contralateral side. But most of the revisions usually end up with a single stage revision where it's almost like a primary surgery. Bone grafting and other complex things you need to consider in about 10% of all your revisions.
So taking that Rajiv's question forward, unfortunately, what I have seen, and you would agree, is that nowadays there are partly anatomic tunnels. They're not completely non-anatomic. They're not anatomic. They're partly anatomic. So you are worried that you'll create a kind of an H-shaped large defect on the femur, and you have to probably graft it. My question is on grafting. We know that ICBG, iliac crest bone graft, is better in terms of incorporation than the allografts, and that is what is freely available to us also. Can you share some tips and tricks as to how you can do a nice arthroscopic double fixation, especially if you can create some sort of a cannulated system? There are reports of the Oates plugs being used and the Oates system, but it's difficult, especially if you have not done the surgery, somebody else has done it, to get the right trajectory. So if you can get a cannulated system where you can put a double inside, any tips you would like to share there?
I think having a wide enlarged portal, the anteromedial portal, when you want to drill on the bone graft on the femoral side, and the technique which I showed where you have a morcellated graft and you cut off the end of a syringe, and then you pass the syringe and then inject the graft in that. I think you can select the diameter of the syringe that you want, and it's very easy to actually pass that instead of anything metallic. So that is what we have done. But like I said, the experience is very little for us to really give some tips and tricks on grafting. But this is what we have done in whatever few cases that we have done, and we had no issues at all. And the graft really
Yeah.
fills up the defect.
Those moralized graft, will they remain there, or you plug that with the votes or megavotes so that they are retained there?
No, they'll be retained there. You just use a tamp to make sure that they are flush with the edge of the tunnel.
Okay.
Always I wanted to ask this question, sir, because a senior surgeon like you can help us. Now, let us say you have in a very bad situation, a second revision, a third revision, all the grafts have been exhausted. And probably the only thing you're looking at is the over-the-top reconstruction. And the over-the-top reconstruction with the ALL technique now, has been pointed out by Zafagnini, is working out well. Any experience with that? Any tips and tricks with that?
No experience with the over-the-top technique. I still feel that it would be completely non-anatomic as far as the ACL is concerned to pass it over the top. My preference would still be doing an anatomic technique and using a free graft for the extra-articular. Combining the two may compromise actually both the surgeries, both the intra-articular as well as the extra-articular compromise.
Okay.
Sir,
Sir, what is your graft choice in revision scenario, sir? It's a bone patella because you want to fill the tunnel also, or it's a contralateral semity or quadriceps graft?
I think the first thing is you want to find out from the patient whether he wants us to touch the contralateral side. So if the patient is reluctant for you to touch the contralateral side, then you are left with very little options. For a failed hamstring, you have to use the bone patellar tendon bone or the CQT. For the failed bone patellar tendon bone, you use the hamstrings or the CQT. But again, if your bone patellar tendon bone has failed, you don't want to touch the CQT. So in a number of patients where we have this dilemma of what graft is to be used, if the patient can afford, we have been using a lot of allografts, and we do at least 2 or 3 allograft reconstructions every year. And there you're spoiled for choice. You can select whatever graft. The diameter of the graft is not a problem. The length of the graft is not a problem. So I think the allograft is an excellent option whenever you're treating a revision case. Because the first surgery may have failed because of poor collagen that the patient has. So usually in females, if the ACL has failed, it may be because of the poor collagen quality that the patient had.
Anant, you have access to allograft from which hospital or which center?
No, we import them. We tried the Indian available allografts and we were not happy at all. So we import them from the US. So now this is a regular feature. There are companies, there is a ConMed, I think, Linvatec, they regularly import allografts and they are able to deliver it within 6 to 8 weeks after placing an order.
So you have been augmenting your primary graft. Do you augment your revision graft also?
All depends on whether the graft is adequate or inadequate. If the graft I feel is inadequate and I need to reinforce it, I'll reinforce it whether it is primary or revision in both scenarios.
There is a question on LET because LET is an important adjunct to a revision ACL. You showed us a technique where you're using an interference screw. Now
Yes.
you would agree there is quite a bit of an incidence of tunnel confluence in spite of dropping your hand and all the tricks, because sometimes the condyle by itself is small. So do you feel the suture anchor is a good technique, a staple is a good technique as comparison to a interference screw?
I think the suture anchor is a better technique if you are worried about tunnel coalition. I feel that a staple becomes prominent, especially on the lateral condyle. It causes a significant amount of bursitis, and usually then it comes in the way of your rehab, getting back range of motion, because the patient is always worried about that clicking that can happen and frequent episodes of inflammatory bursitis that can happen because of a large staple on the lateral femoral condyle. So we would rather use a suture anchor for fixing it on the lateral epicondyle.
Also, sir, I'd like to use this opportunity to ask you, because you are a proponent of flexible reaming, the advantage being you don't need to hyperflex.
Yes,
Do you feel that this technique, the confluence incidence is less because you're creating more horizontal tunnels?
absolutely. And we are far back posterior. So the LET tunnel is way ahead, anterior. So it doesn't bother us at all. And the advantage of these flexible reamers is, I think there are quite a few advantages. Just flexing the knee beyond 90 is one of them. But if you see our ACL reconstructions, they're almost like minimally invasive ACLs because we don't touch the fat pad, we don't touch the ligamentum mucosum, we preserve everything. So the chances of arthropibrosis are significantly reduced because you have preserved everything. The fat pad also plays a role in uh, the gliding mechanism. And so I think the flexible reamers have significant advantages over the rigid reamers.
Right.
So talking about minimal invasive ACL, if there is an avulsion of the ACL from the medial femoral condyle, the patient comes to you early and people have described of reattaching the femoral avulsion using a anchor. Your take on that?
Like an ACL repair, you mean?
Yes.
My experience with the ACL repair goes back to the early 1900s, where Lanny Johnson had this staple for a Bankart, arthroscopic Bankart repair. He had a Lanny Johnson staple. And I used the Lanny Johnson staples in 5 of my patients in those years in the early 90s. One of them was a Maharashtra Ranji Trophy player. The other one is my dentist friend. And somehow these repairs had done very well. But I have realized that the number of repairs that you can do are by and far very, very few. You have to be very selective. You must make sure that the quality of the remnant is excellent. You are not compromising and fixing a frayed or lacerated tissue. You must also make sure that the length of the ACL that remains is not compromised. So you are not fixing it short by shortening the ACL. And I feel in selected patients, so in a low demand individual where I feel that the ACL can be repaired, where they have a low velocity injury to begin with, and they have no other associated lesions like a gross pivot shift, a lateral femoral condyle impact, I would take a chance with a repair of the ACL. So I prefer not to have intra-articular implants. I like to take sutures in the substance of the ACL, retrieve these sutures on the lateral femoral condyle and tie them over a button. I don't like implants within a joint.
And as regards to the timing of surgery, because you said you don't like to operate before 6 to 8 weeks, does it make a difference attaching it early or doing it late?
So again, if you have a bone bruise which is present, so the point in waiting even for a repair is, I tell my patients that in the acute stage your ACL is torn like spaghetti and I would like it to be like pasta before I even venture with a repair. So if you try to take sutures in an acutely injured edematous ACL, you are going to fail because the sutures are going to cut out. And therefore a minimum 4 to 6 weeks of waiting period is what we have found is very helpful, because by that time the ACL thumb becomes a little more solid. It has scarred down a bit and it is easier to take sutures in it and reattach it at the native ACL.
So what about, sir, supplementary fixation and revision scenario? Suppose tibial fixation screw with you. Do you like to add a post? Because
I never use supplementary fixation, and I have never regretted that. We have always used a single fixation right from the time we started surgery, because both from the point of view of economics and also I have not felt the need for. So I have seen a number of surgeons doing hybrid fixation or a supplementary fixation. like in Korea, they routinely were using a staple on the tibial side. But the reason for that is that they got a reason to remove that staple and then have a relook arthroscopy.
All right.
Not because they were bothered about the security of the fixation, but they wanted to somehow get the patient for a relook.
Welcome,
Welcome,
Dr.
Sachin.
Sachin Tapasvi.
Sorry for joining late. Sorry.
That's
Hi,
fine,
Sachin.
but I know that you are held up with the surgery and you
Sorry.
are a busy orthopedic
Well,
surgeon.
please start with the lecture of the
Yes. Okay. I will ask Sachin, what is your experience of treating failed ACL in the revision scenario? Yeah.
So I think failed ACLs probably one of the most important reasons which Dr. Joshi sir must have also shared with his experience is the failure to recognize associated injuries, and that's the second most common reason, and the most common reason is a very poorly placed femoral tunnel, which is why I see failed ACLs in my clinical practice. The challenges, of course, are to try and get a good graft source for these patients. Many a times, if they have been treated with or they have been fixed with biodegradable screws, especially of the first generation, then there is a lot of tunnel widening which may need to be addressed as a two-stage procedure. So I think these are probably three important tips or points that I have observed in my clinical practice so far.
Okay, fine. Yes, Rajiv, you have a question, I think.
Yeah. So Sachin sir, how often you do the alignment X-ray in primary ACL reconstruction, because it has been one of the common cause of ACL failure. We have seen we have missed the alignments. So in primary ACL, how often do you do it?
So in a primary ACL, if there is a reason to suspect that there is malalignment, for example, hyperextension, number one. Number two, if there is a coronal plane deformity that is obvious, or the third scenario where I would always do a long length film is someone who has ACL instability and is say above 35 or above 40 years old. I would always want to do a long leg film to confirm the alignment before I discuss any treatment plan with the same.
So, good evening, Sachin sir, and question first to Dr. Joshi sir, and then I'd like you also to please contribute on that. The question is this: that BTB graft is obviously a very good graft for a revision situation, especially if there is a little bit of tunnel widening on both the femur and the tibia. Now, the problem that I've encountered a couple of times is that if the tendon portion is long, let us say it's above 40 centimeters, then suddenly you have a graft tunnel mismatch. You have the tibial bone plug jutting out of the tibial tunnel. And this can only be prevented if you do a good preoperative planning and you would know that the tendon is abnormally long. However, if you do an outside-in femoral drilling, which I have seen Dr. Tapasvi do in, then you have the option of adjusting that. And Joshi sir, if I'm not wrong, in the early 90s, you all were doing the BTB ACL and fixing it from outside-in technique. So could you guide as to how your tips to preoperatively prevent this and intraoperatively modify this graft tunnel mismatch issues?
So I think to manage this mismatch issue, we have gone back to the old technique of a 2-incision ACL. So we routinely, if we find that the ACL graft is long, we routinely have a lateral incision and pass a screw from outside in. So that is the best way of making sure that you make use of the bone plugs and you have a bone-to-bone fixation both on the tibial and femoral side. So we have gone back to what we were doing earlier.
Right.
I also feel there is a distinct advantage of this two-stage technique, because very often when you are fixing the femoral side, when you are passing the screw keeps on rotating and the graft keeps on rotating, and you invariably end up having a screw which is not on the side of the graft that you would want it to be. So we pass a nitinol wire, make sure that the nitinol wire is on the side of the graft which is facing anteriorly, and then pass the screw holding the nitinol wire on the incision that you have on the outer side if we are passing it from inside out, so that the graft does not rotate and your screw does not keep on rotating the graft. So that has worked very well. In fact, I think this is a excellent tip for preventing damage to the graft when you are passing the screw.
Sachin sir, can you elaborate for the BTB graft tunnel mismatch, outside in tunnel drilling, and screw fixation tips?
Yeah, thank you, Nagraj. A couple of things. First is that once you expose your BTB graft, you can easily measure the tendinous portion of your patellar tendon, and that will be a good guide to let you know well beforehand how long your graft is going to be. Couple of tricks to try and avoid that. One is we try and make a vertical tibial tunnel. Second, you can make a longer femoral tunnel by doing an outside in. But I think one of the most important things that one could do, especially when in a revision situation, when we have tunnel widening, is to harvest a thinner tibial plug and fold the tibial plug, bone plug over the tendinous portion, and then do like a composite technique where you have the tendon and you have the tibial plug that is folded over it, which effectively minimizes the length of your BTB graft, and it adds to the bulk of your BTB graft as well, thereby allowing you to fill a dilated tunnel a lot more easier.
That's a great tip, sir.
Rajiv.
Yeah, Sachin sir and Anand Joshi sir, question to both of you. For revision scenario, what is your ideal fixation choice at the femoral side? It's you want to do a aperture fixation or you want to do a suspensory fixation?
I think depends on the graph that you are using. If it is a CQT that I use, I always use a distant fixation on both sides. If my graft is long enough that on the tibial side it is almost at the tibial aperture, then I use a aperture fixation on the tibial side. But on the femoral side, it is usually a distant fixation.
Yes,
So I
Sachin
think
sir.
again, yeah, I think I'll agree with what Joshi sir has said, and most of us have learned from him, and what we are today is because of Anand Joshi sir only. So the most important thing is that a lot of the decision to do a double fixation or not depends upon the quality of bone that you have. If you have excellent quality bone, if I have a bone to bone like a BTB or the bone plug of the quad tendon, then a single interference screw is good enough. But if there's compromised bone, then I would not hesitate to do a double fixation. For example, if I'm doing a soft tissue graft and I pass the soft tissue graft, fix it with a suspensory loop, to supplement my fixation at the aperture, I use the bio-shim technique, which was popularized by Strobel, in which you have a small little curved gouge or an osteotome just 3 millimeters above the proximal or the superior margin of the tunnel. You go in with that osteotome to a depth of about 20-25 millimeters, and then push your hand down so that you're literally doing something like an osteoclasis and pushing down a thin rim of bone over the soft tissue, and I pass this.
We lost him.
Some
Yeah,
network
we lost.
issue is there.
Yeah.
That there is
Yeah.
a problem with the quality of bone, then in those situations, and I will do a double fixation with a fixation post as well. But I actually depends upon the quality of graft and the quality of bone that you have.
Dr. Joshi sir, you mentioned about stacking of screws. So do you retain the previous hardware if it is not coming in your way, or do you get everything out and let the cavities be in a revision situation?
So on the femoral side, if the screw is not coming in my way, I don't make any effort to take it out. But on the tibial side, very often if it's a screw fixation on the tibial side, you invariably end up removing that screw because that comes in the way of your tunneling. So femoral side implants, unless they are proud or they are going to hamper the way you're doing it, or they are migrated loose, only then we would make attempts to remove it. If they are not coming in our way, I don't want to extend my surgical procedure unnecessarily.
Same with you, Sachin sir?
Yes, sir, absolutely.
Yeah, removal of the screw is so difficult from the using the
Difficult,
arthro.
and you make lots of damage also to the bone there. Ultimately, that hampers your fixation of your division graft also.
Yes. Any last question anybody has to ask anybody?
What should
Yeah,
be
yeah. Anant, do you have any question to ask to Sachin?
Yeah.
No, I have one question
Yes.
to ask, sir.
Questions I
So
call
one,
up Sachin.
Yes.
Anytime I have a problem, we call up Sachin.
yeah.
Yeah, correct. Yes. Yes, Sachin.
Sir, my most important question is, which is not written anywhere in the textbook or in any scientific literature. I do a patient. He comes with a ACL, which is a re-rupture. How do you counsel him? How do you counsel your own operated patient that you require a revision surgery? What are the steps that you go through to make him understand that this is an important procedure, this is essential, especially so if he's done well and you want to do a 2-stage, or let's even say a 1-stage. Let's not complicate it. So what are the things that you will go through? Because what I feel is that these people need a lot more counseling. So how would you counsel these patients?
So I think counseling these patients, especially if they have a re-injury, is extremely easy because they understand that the index injury and the fresh injury are almost similar.
Yeah.
And the bone bruise patterns, you have the MRI in front of you. You can explain to them that in the previous MRI and this MRI, it is very obvious that the injury pattern was the same. And just as you could damage your other knee, similarly, you have damaged the knee which has been operated and the ACL is torn. Very often it is easy to counsel these kind of patients. But when a patient comes to you where there is a biological failure of the graft, that is something which is very difficult to explain to patients as to why on the MRI the graft has just disappeared and vanished and it is not seen at all. And in those patients, they start wondering whether we have done an ACL in the first case at all, scenario at all. And that is where you need to really counsel them, saying that, basically a ligament cannot be replaced by a ligament in the current scenario. What we are doing is replacing a ligament with a tendon, and how your body is going to adapt this tendon and convert it into a ligament by the ligamentization process is something which is not in our hands. So I think if you take time with your patients and you explain to them properly, I think a large number are willing to accept the counseling that you do.
Yes.
What is the percentage of graft resorption? What you are telling?
A biological failure of the graft.
Yeah, biological failure of graft
Is something which is completely unexplainable, and that's why I feel that if you can preserve biology to whatever extent possible during the index ACL, that helps, because after all it is dead collagen, and how that dead collagen is going to survive in the joint is anybody's guess. So it is something which is not something unexplainable.
Yes, last question. Yes, Nagraj.
one question I'll ask. Joshi sir just mentioned about tunnel dilatation as 13 millimeters cutoff, beyond which you would advise a 2-stage procedure. I'm trying to utilize the experience of both you and Sachin sir here, because if, like he mentioned, if it's a first generation bioscrew, when you are counseling the patient pre-op, you would be telling him that I would try for a single stage procedure, but intra-op, if I find that it suddenly widened up, we might have to do a 2-stage procedure. So what I want to know here is what should be the cutoff with your experience with the multiple stacked screw technique, with the bone plug technique. Can you actually go up to 15 millimeters? Because the literature says 15 to 16 millimeters is the cutoff because of these tricks. So what has been the experience, especially on the tibial side? Because I think on the tibial side, if the bioscrew is there, when you start putting your reamer, it suddenly opens up. The whole thing just opens up. So what should be the cutoff in terms of counseling these patients about how often you'll be able to do a single stage?
I think my decision to do a single stage and a second stage is done with the pre-operative assessment. I don't do it on the table. And I am very clear with my patient. I want to tell them that I don't want to operate you on a third time. So whenever, whatever we are doing is basically planning your surgical procedure to the T. so that if I need grafting, I want to make sure that the graft is completely incorporated before we go in for the second procedure, that's a proper reconstruction. So I think one must make sure that the patient has full confidence in you, and you are very firm about doing a single or a two-stage procedure and not take a decision on the table.
Anant Joshi, for you, it may not be difficult to convince because they know that you are the final answer. But for people like Asit or Nagaraj or even Rajiv Raman, it will be sometimes difficult.
No, I think it is wrong. Patients can see through the sincerity of a doctor. So if you are very sincere, and they can read, the patients can read through a doctor whether he is sincere or not, and they can basically they can see whether you are giving them a right opinion or not. And of
Yes.
course, they go through Google and they come to go through everything and then come to you.
Let me just elaborate on that, sir. So let us say I have counseled the patient that I'm confident of doing a single stage, but intraoperatively, once I removed the bioscrew and whatever remnants were there, I realized that there's a large cavity left now, and I know my BTB and my stacked screw technique may or may not get me a good ideal fixation. So that with this in mind, I always counsel my patients that my final decision is going to be intraoperative. What I want to know from you is, with this stacked screw technique and a big bone plug, up to what amount of dilatation can we compensate on the tibial side?
Marginal. Very marginal. I wouldn't rely on the stack screw for a large defect. I would definitely go for a two-stage procedure. All these things can compromise your fixation. These are just bailouts and for marginal tunnel enlargements. But for a massive one should not rely on these kind of bailouts.
Sachin sir, I asked this question because in your PKC talk by Andy Williams, he talked about this, and majority of the times managing a single stage reconstruction. Could you elaborate? What's your take?
That's actually his personal choice, and probably he's good at it. That's why he does it. But I would absolutely go with what has been discussed before. Large dilatations beyond 12, 13, 14 millimeters are important, and it does become very difficult to treat them as a single stage. More important than the number of millimeters is actually the position of the tunnel. And on the tibial side, if you have a tunnel that is posterior, then that really can cause a lot of problems. A dilated, slightly posteriorly placed tibial tunnel will compromise your fixation too much, and that's why many a times you would need to want to go and bone graft those tunnels. Probably where Dr. Andy Williams is coming from is that he has a series in which he's looking after his own patients predominantly. He uses metal screws for everyone, so he doesn't face that huge a problem of tunnel dilatation. And most of the patients in his series, they are professional soccer players and other sportsmen. The major etiology is re-trauma, and they don't have to deal with complex problems like what we have to deal with. We have malpositioned tunnels and some compromised material screws which are being used, which have a totally different presentation. I mean, correct me if I'm wrong, Joshi sir, but I feel we are dealing with two different patient groups and patient types completely here.
So no more questions. Okay. Thank you very much, Dr. Anant Joshi. That was an excellent exposure to field ACLs, and as you really correctly said, it is the revisions are mainly because of the not done properly done primary ACL. That's why you are getting those cases. So the people who are watching this webinar, the take-home message is do the things correctly for the first time. That's very, very important. That is what that has to be taken care. We have the option of doing revision, but everything has to be done rightly. If you are not prepared, as Dr. Sachin Tapasvi said, doing with inferior quality screws and other things are also problematic. So be prepared to tackle all the things, including the malalignment, because just doing a ACL reconstruction may not work if the patient has a varus thrust or even the posterior slope is not correct. So all that have been very well explained. So be prepared to tackle all the things, then only you should be going to the theater to do the thing. And next week, we have got a very good webinar again on trauma series. Dr. Anil Bhatt from KMC Manipal will be talking on distal radial fractures from police fracture to corona time. Then on Thursday, we have got Dr. Deen Dayalan from Coimbatore Ganga Hospital talking on non-union of the fractures of the humerus. I thank Dr. Anant Joshi for taking off his time to share his vast knowledge with all of us. I would like to also to thank Dr. Sachin Tapasvi, Dr. Nagaraj Shetty, Dr. Rajiv Raman, and Dr. Asit Chidukar for joining to take this beautiful webinar to a very good conclusion by very good discussion. Thank you, Dr. Ashok Sham, Dr. Neeraj Bijlani, and Dr. Dheeraj Attade. And I'm stopping. Yeah. Ashok, you can stop the live stream.
Thank you, sir.
1 minute.
Yes.
Thank you.
Yeah.
Thanks,
Okay.